let's go ahead and get started. How are you guys this morning? All good? For the most part? All good? Good. Happy Wednesday. All right, so today we have the goal that we need to accomplish of finishing up our discussion on the endocrine system. On Friday, we had talked about what hormones are. We talked about the fact that they travel through the bloodstream, they bind to a receptor, and they have some sort of an effect on the body. We also talked about the chemical types of hormones, whether they're steroids or proteins, or whether they're derived from a single amino acid. And depending on that chemical composition, where they bind to their receptors. Remember that protein hormones are largely lipophobic, and as a result of that, they have to bind to receptors that are extracellular. And that will often involve the use of some sort of a second messenger inside of the cell. And then we also talked about how lipid hormones, lipophilic hormones, steroids, are going to be able to bind to a receptor inside of the cell. They usually, that hormone receptor complex is going to act as a transcription factor and results in the transcription of new proteins. And then in lab, what we started to do is we started to look at a couple of glands. We didn't make it terribly far, but we did get through the pituitary. We looked at the posterior pituitary, and it's an extension of the hypothalamus, neural tissue. And then we looked at the anterior pituitary, which is glandular tissue, and it's also under the direction of the hypothalamus as well. There are separate neurons in the hypothalamus that control the anterior pituitary. And then we looked at those anterior pituitary hormones, and we saw that of the 6 hormones secreted, 5 of them are what we call trophic hormones, meaning that they affect other endocrine glands. And then we kind of left it at this. We did start to introduce the thyroid. We'll pick up today in lab with the thyroid and start to take a look at it. But this is kind of where we left the discussion of these response loops on Friday, especially with what we call the hypothalamic anterior pituitary axis. We see that in this sort of a situation where the hypothalamus is controlling the anterior pituitary, and 5 out of the 6 of those hormones are controlling other endocrine glands, we end up with a response loop where there are multiple integrating centers. And we were talking a little bit about how hard it is to diagnose these sorts of issues, as well as treat these sorts of issues as well. We do have multiple levels of negative feedback in these sorts of situations. We have what we call short loop and long loop negative feedback. Anyway, that's kind of where we left things on Friday. If you missed on Friday, there's a very quick and dirty summary of what we talked about. Does anybody have any questions about anything that we talked about on Friday before we dive into new stuff today? Cool. It's all perfectly clear, huh? It's exciting. I like that. All right, let's go ahead and keep on going. So I do want to kind of pick up here again this morning, where we sort of left off on Friday with these response loops that are part of this hypothalamic anterior pituitary axis. Okay? Because this is an interesting chain of events that can be, as I said, kind of hard to diagnose and also sort of challenging. As I said, we're going to pick up again with the thyroid today, and we're going to talk about the thyroid and what it does. I want to go ahead, for the purposes of lecture this morning though, and I want to skip ahead to the adrenal gland. We'll come back to the adrenal probably again in lab this morning, because there's quite a bit to talk about regarding the histology here. In fact, we're going to spend quite a bit of time with the histology of the adrenal gland this morning. But because that slide that I just had up uses the adrenal as a example, I want to go ahead and kind of focus on the adrenal for a little while this morning. And I want to talk about short versus long-term stress. All right. I think that's probably something that we can all relate to a little bit, right? So I wanted to spend a little bit of time. And then what I want to do is I want to bring it back to what we were looking at just now with those responses. So the adrenal gland is a gland that we've already talked about a little bit because we talked about adrenal sympathetic pathways, right? So we talked about the release of epinephrine and norepinephrine from the adrenal medulla. So we already are a little bit familiar with the adrenal gland. And we'll return very briefly in lab today to the adrenal medulla because I want us to look at it under the microscope, all right? But for the time being, let's spend some time talking about the adrenal cortex. The cortex is that outer part of the adrenal gland that we see right here. And like the pituitary, the adrenal gland is kind of two glands smushed into one. The adrenal medulla is possibly some sort of has ancestral roots as neurons. The cells that make it up are these glandular chromatin cells. Again, we'll take a look at those a little bit later today in lab. But the cortex is unique because this is one of the few endocrine glands in the body that secretes steroid hormones. Okay, so the adrenal cortex secretes steroid hormones. In fact, it secretes a lot of steroid hormones. We're going to go ahead and kind of divide them into 3 families rather than go through all 24 of the hormones that the adrenal cortex secretes. And we're going to kind of name some representative hormones when we get to them. But there are 3 families of hormones that the adrenal cortex secretes. The first family of hormones that the adrenal cortex secretes is a class called the mineral corticoids. Okay? The mineral corticoids are best represented by the hormone aldosterone. And we'll talk a lot about aldosterone a little bit later on in the class when we talk about the kidneys. You guys remember last week we talked about the posterior pituitary hormone, vasopressin, or antidiuretic hormone. And we said that generally that's a water conservation hormone, right? In a very similar way, aldosterone is also a water conservation hormone. It makes us retain water, but it does that by making us retain salt. So aldosterone has a really big effect on our blood pressure. All right, we'll talk about its role in blood pressure regulation when we talk about the kidneys later on in the class. But all of the mineral corticoids, to some degree, have a role in blood pressure homeostasis as well as water retention. Okay. The next class of hormones that we have are the glucocorticoids. The glucocorticoids, we have cortisol that's released from the adrenal cortex. Sort of the over-the-counter synthetic version of cortisol is something that you're probably familiar with called cortisone. You might put it on itchy spots and things like that to help to relieve an itch or something like that, kind of skin irritations. But those are examples of glucocorticoids. Glucocorticoids generally promote glucose metabolism, but they can also go one step farther. They can also release prostaglandins to help to reduce swelling, which is why we put synthetic glucocorticoids on our skin when we have skin irritation. But they can do a number of other things as well. Glucocorticoids are fairly involved. We'll talk about them in just a little bit more detail here in a second. And then finally, our third family of hormones that we secrete from the adrenal cortex are what we call the gonadocorticoids. These are the adrenal sex hormones. So normally when we think of sex hormones, we think of the gonads being released, right? The testes and the ovaries. But the adrenal glands also secrete very low levels of sex hormones. Testosterone is primarily secreted from the adrenal cortex in both men and women and everybody. But there are certain cells that will convert it to estrogen. This is most important before puberty sets in. we need very small amounts of these hormones, like testosterone, just for normal development. And so the adrenal cortex is going to supply those. Of course, once puberty begins and the gonads start to secrete either estrogen or testosterone in really large amounts, they obviously kind of trump what these guys are going to be secreting. Prior to that, the adrenal cortex is responsible for those low levels of sex hormones that are needed for normal development. Right? So 3 different classes of steroids that kind of have different functions, right? We have one that works in blood pressure homeostasis and water conservation. We have one that works in mitigating glucose metabolism and to sort of a lesser degree metabolic rate. And then we have gonadocorticoids, which are largely helping to regulate development and things like that. So 3 very different classes of hormones. We'll talk about this in lab today. I'm not skipping it intentionally right now. A little bit more about cortisol. So cortisol protects us from low blood sugar. And it kind of has 2 roles in our body. Cortisol sort of has a normal, everyday sort of a role, and then it has sort of a crisis role. Its normal, everyday role is one in which it just promotes glucose metabolism at certain times of day to prevent our blood sugar from getting too low. That condition where we have low blood sugar is called hypoglycemia. We can see that cortisol is secreted in a fairly regular rhythm throughout the day. It looks a little bit funny, but you can see here that cortisol levels tend to be quite low around noon. They tend to peak, have one peak in the early afternoon. They have a much lower peak around midnight, and then sort of mid-morning they have a second peak over here that actually is quite big. You guys should be getting close to your second peak, or your big peak of cortisol here in just about the next hour or so. And again, what it does is that during those peaks, it promotes glucose metabolism. We should see a natural rise in blood sugar levels that kind of correspond to that. And if you look at it, it's kind of interesting because the places or the times of the day when cortisol levels are low are very often when we eat meals, right? We see that it tends to be the lowest at around 6 a.m. or just a little bit before 6 a.m. This is probably when you start getting hungry for breakfast in the morning. It also tends to be really low around noon, around the time of the day that you eat lunch. And then it also tends to have a little bit of a dip sometime between 6 p.m. and midnight, which I guess might be a little bit late for dinner, but maybe Europeans have it right. That's if you're in Europe, that's when you're going to eat dinner. It's you go to Spain or something like that, you're going to be having dinner around 9 o'clock at night. So maybe they have it right. So it's kind of an interesting thing that we do start to get hungry. We start to experience that low blood sugar and start to feel that feeling of hunger during the times when our cortisol levels are very low. But during the times when they're high, we tend to be not quite as hungry and we tend to feel a little bit more satiated. So it's kind of an interesting one. In its crisis mode, however, cortisol can go a step farther. Cortisol promotes a process called gluconeogenesis. Gluconeogenesis is an interesting biochemical pathway, and what its goal is, or what its job is to produce new sugar from other fuel sources. So that name, gluconeogenesis, right? We look at it, we see that genesis is the creation of, right? Neo is new, and gluco means sugar. So this word literally means the creation of new sugar, okay? There are some tissues in your body, especially your central nervous system, your brain and your spinal cord, that can only use glucose as a fuel source. They can't use proteins or fats as a fuel. So you have to have a little bit of sugar in your system in order to be able to fuel those really important organs, your brain and your spinal cord. So when there is no sugar available, what your body can do is it can make sugar from amino acids and fatty acids, and that's called gluconeogenesis. Okay. You typically only do this, though, when you don't have any sugar in your diet. What are some circumstances in which you may not be bringing sugar into your body? You may know.
I don't know if it's the opposite or not, but diabetes.
It's a special case. Let's hold off on diabetes for a minute. Okay. You might have sugar in your diet, but there's something else going on there. Okay. But we'll talk about that because that's a good one. But let's hold off on that one for a second. What else? Well, one of the things that comes to mind is there are people who just elect not to eat sugar, right? What do we call that kind of a diet when you have very low to no sugar? What? No, we're not diabetic. What do you call a diet if you elect not to do it? Keto, what? Keto diet, right? We'll talk about why it's called a keto diet here in just a moment. So you could elect not to eat it, okay? You might not be eating at all, okay? Whether by choice, right? We have eating disorders that people elect not to eat. We have things like anorexia and bulimia where people elect not to eat. And of course that's a pathology that needs to be treated. But you can also not be eating, not by your own will. You might not have access to food, right? That's a real, it's a reality for not only people in our country, but for people all around the world, right? So there are instances in which people may not be eating sugar. They might need to do gluconeogenesis, right? Cortisol is going to help to facilitate that. Now, diabetes is a little bit of a special case because it doesn't necessarily mean you're not eating food, right? But in order for your cells to use sugar, you've got to be able to get that sugar into the cells in the first place, right? And the hormone insulin that's released by the pancreas is going to allow us to get that sugar into the cells so that it can be used. And people who have diabetes, they're essentially unable to get that sugar into their cells. So somewhat paradoxically, they can have a really, really high blood sugar level, but the cells don't have access to it, and the cells are suffering from a hypoglycemic sort of a situation. So it's a little bit of a paradoxical thing, but it is a great example of a time when we might run into gluconeogenesis, right? So cortisol helps to facilitate gluconeogenesis. It makes fuels available for gluconeogenesis, so it can break down skeletal muscle protein, okay, because that's a major protein source. It can start to break down skeletal muscle protein, and it can also break down fat via a process called lipolysis, because it's freeing up fuel sources for gluconeogenesis, okay? So gluconeogenesis is a real thing, and it can come about in a number of different ways. It does produce sugar. It also produces a byproduct called ketone bodies. Okay, it also produces things called ketone bodies. Okay, ketone bodies are a waste product that needs to be eliminated. They also are acidic. So if you have a lot of ketone bodies building up in your system, we call that state ketoacidosis, right? Ketoacidosis. This can be a big disruptor to acid-base balance, which we'll talk about later in the class. So this can lead to ketoacidosis. Again, it can really disrupt acid-base balance in the body, and we have to deal with that somehow. So we'll again talk about that later on in the class when we get to acid-base balance. For what it's worth, you can detect ketone bodies very, very easily in the urine. There are very easy urine tests that you can detect ketones in the urine to determine whether or not somebody is maybe not metabolizing glucose the way that they should be, or needs to make more glucose, I guess I should say. In fact, we'll do a urinalysis later in the class on your own urine, where you can test your own urine for ketone bodies. If it gets really bad and somebody's making a lot of ketones, we're not just going to be able to detect it in their urine. Ketone bodies have a fairly sweet smell to them. You can actually smell them on a patient's breath. So if you have a diabetic who has really high blood sugar, for instance, or you have somebody with an eating disorder or who's, for lack of a better term, starving to death, you can actually smell the ketones on their breath. Their breath will smell really sweet as a result of that. So that can be a really quick indicator for you in the field to determine whether or not you need to take interventions to help them get some more sugar into their system. Okay, obviously you'll learn a lot more about that when you kind of get into different things. But gluconeogenesis is a really interesting pathway, and then cortisol facilitates it by helping us to break down protein as well as fat. And then finally, cortisol also suppresses the immune system, and it does this to help us to save energy. Okay, our immune system functions take a fairly big part of our daily energy budget. Those cells are working very hard to keep you well. And you probably are aware of budgets, maybe not energy budgets, but you're probably aware of your own budget. You get a paycheck every month with a certain amount of money, and you have to decide how to spend that money, right? Sometimes you need to buy food, you need to pay rent, maybe you have a car to pay for. You have all of these things in your budget every month. You probably have realized that if you can avoid paying for something in any given month, it gives you more money to do other things, right? It's kind of nice when you get to skip a car payment or something like that, because that's an extra few $100s in your bank account every month. It's funny how quick it goes at the end of the month, right? I'm sure glad it's almost October 1st. I don't know about you, but I am. At any rate, you guys are aware of budgets, right? Energy budgets are the same way. You have to allocate energy to certain things, and the immune system is one of them. If you take that slice of pie out of the system, if you suppress the immune system, you can use that energy for other things, which can benefit you in times of stress. Okay, so it may not seem immediately obvious, but it's kind of an interesting one. So as a result of the adrenal glands' functions, we have kind of a response to short-term stress, but we also have a response to long-term stress. Okay? So short-term stress is something that we've already talked about. It involves that adrenal sympathetic pathway. These are things that are short-term stressors that don't typically last very long, right? Narrowly avoiding a car accident is a great example of a short-term stressor. Maybe you're on a hike somewhere and out in the desert, and you see a rattlesnake that surprises you or something like that. That's a short-term stressor. You get away from it, it's not going to chase you or anything like that, but it definitely causes that adrenal sympathetic response, right? So we see, as a result of the catecholamines, epinephrine and norepinephrine, we see that we have increased heart rate, increased blood pressure. We convert a whole bunch of liver glycogen to glucose to make glucose available to our cells. Our bronchioles, our lung passageways dilate so that we can bring more air into our lungs. We have changes in blood flow pattern that cause us to be a lot more alert, and we just have an increased metabolic rate. But these typically don't last for very long. Short-term or long-term stress is a little bit different, right? Long-term stress can last for days, and in some cases even months or years. Okay, so this is your adrenal cortex at work, and two of those families of hormones, the mineralocorticoids and glucocorticoids, are usually hard at work here. So the mineralocorticoids are released in times of long-term stress to help us to retain water. Okay. You might be thinking, why would I need to retain water during long-term stress? Here's some examples of long-term stress that you might experience, or somebody might experience. Yeah?
Let's say you crash your car and you have to make the damages.
Sure, long-term financial stress. Yeah. What else? Having a kid. Yeah, that's a short, the 18-year-long source of stress. Maybe longer, I think. I don't think it ever ends. What else? Maybe being enrolled in 50B. That could be an example of a long-term stressor, right? What ancestors out roaming the post-glacial plains of North America, hunting mammoths, things like that, right? Definitely not knowing where your next meal is coming from can definitely be a source of stress, right? Healing from long-term injury, right? You crash your car and you're injured, and it might take you months to recover from some of these injuries, right? To fully recover. I have a friend who was riding his bike a little bit over a year ago on a dirt road in Colorado and was hit from behind by a driver on a cell phone. And he was hit pretty much square from behind at about 40 miles an hour by this truck. He's really lucky he's alive, but he's definitely not over his injuries yet. He's still recovering from his injuries. The bike got thrown in the trash can, but he's still recovering from his injuries. So you can definitely see that those sorts of things can last a very, very long time, right? You know, we have all sorts of post-traumatic stress disorders and things like that that can cause all sorts of long-term stress. So it comes in lots of different ways, right? But what do we do to cope with that? Our body's going to help us to survive, right? And one of the things is that we're going to help to retain water. Again, that might not seem immediately obvious, but if you don't know where your next drink of water is coming from, the last thing that you want to be doing is urinating all over the place, right? Just dumping water left and right. We don't want to do that. We want to try to hold that water inside of our bodies, okay? By holding that water inside of our bodies, it causes an increased blood volume and increased blood pressure. And then we just talked extensively about glucocorticoids, but we're going to be breaking down protein stores, which is largely our skeletal muscle, and fat in order to convert them to glucose so that we have energy for different things. We are going to suppress our immune system as well to take that slice of pie out of that pie chart of things that we have to spend energy on so that we can spend it on other things as well, right? So those two hormones are going to help us to get energy and conserve water so that we can hopefully help to survive this long-term stressor. Is there anything in that list, though, of things, especially on the right-hand side, on the green side of the screen, the more prolonged stress? Is there anything in there that maybe isn't so good for us over time, though?
Yeah.
Like what? Increased blood sugar, right? We don't want our blood sugar to be high for a long period of time because it can put us at risk of developing diabetes, right? We'll talk about diabetes in lab a little bit more today. And then, of course, increased blood pressure as well, right, from the mineralocorticoids. Long-term elevated blood pressure is also not good for our health. It can really put a lot of stress on our blood vessels, put us at risk for things like atherosclerosis and things like that as well, right? So we see kind of a common theme in physiology here. We see a situation where we're getting some benefits from this stress response, right? We're getting some benefits that are going to help us to survive. We're conserving water, we're creating a source of energy for ourselves so that we can survive this stressor. But at the same time, we're also seeing that those benefits come at a cost, right? So it's not perfect. They aren't just benefits, right? They're coming at a cost. And this happens a lot in physiology, where we see that there are these called trade-offs that occur, right? Where we get something good out of a situation, but it might come at a little bit of a cost. You know, that's just sort of the way that we evolved. We did not evolve for perfection. We are the result of evolution, and the result of evolution is compromise. And I think that this is a really good example of that, right? So it's kind of an interesting thing to remember. All right. So the adrenal medulla, short-term stress, adrenal sympathetic pathway, and then we have adrenal cortex, long-term stress, and that's the adrenal cortex that's responsible for that. Any questions about that? Okay.
Is there a specific pathway for the cortex?
It is just the blood that carries ACTH. So remember that the cortex is stimulated by an ACTH, which comes from the anterior pituitary gland. And the anterior pituitary gland is under the direction of the hypothalamus. So if we go back to this slide, go back to this slide, we see that we have that pathway right here. Okay? We have the hypothalamus. The hypothalamus releases a hormone called corticotropin releasing hormone, or CRH. Again, it's not one that I'm going to make you guys memorize. I told you guys you don't need to know those hypothalamic hormones. But it is under the direction of the hypothalamic hormone. The anterior pituitary, in response to corticotropin releasing hormone, is going to release ACTH, adrenocorticotropic hormone. That acts on the adrenal cortex to release cortisol and aldosterone, and then the target tissue leads to a response. Okay. So, what this does is it creates a situation where we have to look at how we might diagnose and manage a situation in which we're dealing with this hypothalamic anterior pituitary, and in this case, adrenal cortex axis. So what I wanted to do is I wanted to canvas really quick. Oops. Hold on. Let's see what happened in here. Ah, I do. Okay, I'm going to make this video live. I'll change the date on it. This is from a previous semester, but I'm gonna show you guys this video really quickly. So this is a video about a disorder called Cushing syndrome. So I want to watch this. So the idea here is that we're going to be looking at that hypothalamic anterior pituitary adrenal axis. And the situation here is that we've got a patient who has chronically elevated cortisol levels. Okay? So the question is, where is that cortisol coming from? And how are we going to figure out where it's coming from? Okay, is it coming from too much ACTH from the anterior pituitary, or is there something going on with the adrenal gland itself, right? That's what we want to look at here. When we have, well, he's going to explain that elevated cortisol is called Cushing syndrome here. So let me go ahead and make this big and look at my volume control here.
Cushing syndrome, named after the famous neurosurgeon Harvey Cushing, who first described it, is an endocrine disorder with elevated cortisol levels in the blood. In some cases, Cushing syndrome results from a pituitary adenoma making excess ACTH, and in those situations it's called Cushing disease. Normally, the hypothalamus, which is located at the base of the brain, secretes corticotropin-releasing hormone, known as CRH, which stimulates the pituitary gland to secrete adrenocorticotropic hormone, known as ACTH. ACTH then travels to the pair of adrenal glands, on top of each kidney, where it specifically targets cells in the adrenal cortex. The adrenal cortex is the outer part of the adrenal gland, and is subdivided into 3 layers: the zona glomerulosa, the zona fasciculata, and the zona reticularis.
We'll talk about those zones in lab.
The zona fasciculata is the middle zone, and also the widest zone, and it takes up the majority of the volume of the whole adrenal gland. The ACTH specifically stimulates cells in this zone to secrete cortisol, which belongs to a class of steroids, or lipid-soluble hormones called glucocorticoids. Glucocorticoids are not soluble in water, so most cortisol in the blood is bound to a special carrier protein called cortisol-binding globulin, and only about 5% is unbound, or free. In fact, only this small fraction of free cortisol is biologically active, and its levels are carefully controlled. Excess free cortisol is filtered in the kidneys and dumped into the urine. Free cortisol in the blood is involved in a bunch of stuff, and it's part of the circadian rhythm. Cortisol levels peak in the morning when the body knows we need to get up and go, and then drop at night when we're getting ready for bed. In times of stress, the body needs to have plenty of energy substrates around. So cortisol increases gluconeogenesis, which is the synthesis of new glucose molecules, as well as proteolysis, which is the breakdown of protein, and lipolysis, which is the breakdown of fat. Cortisol also helps to maintain the blood pressure by increasing the sensitivity of peripheral blood vessels to catecholamines, like epinephrine and norepinephrine. And this narrows the blood vessel lumen. Cortisol also helps to dampen the inflammatory and immune response by reducing the production and release of inflammatory mediators, like prostaglandins and interleukins, as well as inhibiting the proliferation of T lymphocytes. Finally, cortisol receptors are present in the brain, where their full effect is still actually unclear, but might influence things like mood and memory. For all this to work properly, though, the levels of free cortisol have to stay within the normal range. To do that, the body uses negative feedback, which means that high levels of cortisol tell the hypothalamus and pituitary gland to decrease their secretion of CRH and ACTH, respectively. Less CRH also tells the pituitary gland to make less ACTH, so the pituitary gland ends up having two reasons not to make ACTH. With less ACTH floating around, the zona fasciculata gets less stimulation to make cortisol, and eventually cortisol levels go back down to the normal range again. In Cushing's syndrome, cortisol levels are constantly higher than normal, so its effects are exaggerated. Excess cortisol leads to severe muscle, bone, and skin breakdown, which are the major protein stores of the body. It also leads to elevated blood glucose levels, and that leads to high insulin levels. Insulin, among its many actions, preferentially targets adipocytes, or fat cells in the center of the body, around the waist and buttocks. In those cells, the insulin activates lipoprotein lipase, which is an enzyme that helps those adipocytes accumulate more fat molecules. The result is central obesity. In addition to this, the high cortisol levels cause hypertension, and this is for two reasons. First, they amplify the effect of catecholamines on blood vessels. And second, cortisol starts cross-reacting with mineralocorticoid receptors, which normally only bind a related steroid hormone, mineralocorticoid, which are secreted from the zona glomerulosa layer of the adrenal cortex. In other words, because the cortisol is structurally similar to mineralocorticoid, it can bind to that receptor, and it can trigger the mineralocorticoid effect, which is mainly to increase blood pressure by retaining fluid. High levels of cortisol also inhibit the secretion of gonadotropin-releasing hormone from the hypothalamus, which messes up normal ovarian and testicular function. Excess cortisol also dampens the inflammatory and immune response, making individuals more susceptible to infections. Finally, high levels of cortisol seem to impair normal brain function, but the exact mechanism here is unclear. Cushing's syndrome can happen because of exogenous cortisol, meaning that it comes from outside, usually in the form of medications. But it can also happen because of endogenous cortisol, meaning that the excess cortisol is made by the body. The majority of cases of Cushing's syndrome happen in individuals using exogenous steroid medications over a long period of time, often to treat autoimmune and inflammatory disorders, like asthma or rheumatoid arthritis. That's because the molecular structure of exogenous steroid medication is so similar to cortisol that they mimic its actions on various tissues. In fact, exogenous steroid medication can also cause negative feedback on the hypothalamus and the pituitary gland. This causes a decrease in CRH and ACTH, which in turn shuts down cortisol production from the zona fasciculata. Over time, this lack of stimulation can cause the zona fasciculata to physically shrink or become atrophic. Since that's the widest part of the adrenal cortex, it can have a measurable effect on the overall size of the adrenal gland. Even though this results in less endogenous cortisol production, it still doesn't quite compensate for the huge levels of exogenous cortisol, and that causes Cushing's syndrome to develop. In addition to taking exogenous steroid medications, Cushing's syndrome can also result from increased levels of endogenous cortisol. The most common reason for that is excess ACTH. The leading cause of that is a pituitary adenoma, which is a benign tumor of the pituitary gland, and this specific condition is called Cushing disease. The exact reason for the development of this sort of benign tumor isn't known, but unlike a malignant tumor, the cells don't invade neighboring tissues or spread to other parts of the body. Instead, the pituitary adenoma simply grows in size and secretes too much ACTH. The excess ACTH overstimulates the zona fasciculata of both adrenal glands, which grow larger and secrete excess cortisol. Apart from pituitary adenomas, there are ectopic sources of ACTH, like small cell lung cancer. And in these cases, the excess ACTH is coming from somewhere other than the pituitary. Another common cause of endogenous Cushing syndrome is tumors of the adrenal glands that make excess cortisol, like adrenal adenomas, which are benign tumors, and adrenal carcinomas, which are malignant tumors. In both adrenal adenomas and carcinomas, the cells of the zona fasciculata within the adrenal cortex start dividing abnormally and secrete excess cortisol. As before, the excess cortisol provides negative feedback to the hypothalamus and pituitary gland, suppressing both CRH and ACTH production. Although this doesn't have any effect on the zona fasciculata of the involved adrenal gland, since the neoplastic cells are autonomous, meaning that they've grown independent from any stimulatory signals, the zona fasciculata of the uninvolved normal adrenal gland shrinks and produces less than the standard amount of cortisol. The net result, though, is still abnormally high levels of cortisol, and that causes Cushing syndrome to develop. Regardless of the cause, the symptoms of Cushing syndrome are directly related to the effects of excess cortisol on its various target tissues. Resulting from the increased breakdown of most types of tissue, the individual presents with muscle wasting in thin extremities, skin thinning, easy bruising, and abdominal striae, or lines, as well as fractures due to osteoporosis or brittle bones. At the same time, there's fat redistribution. So classic findings include a round, full moon-shaped face, a buffalo hump, which is a fatty hump on the upper back, and truncal obesity, where fat gathers around the abdomen and trunk rather than in the limbs. Finally, excess cortisol causes hyperglycemia, or high blood sugar levels. That can progress to diabetes mellitus, hypertension, or increased blood pressure, along with a high risk for cardiovascular disease, as well as increased vulnerability to infections, or wound healing, amenorrhea or absent menstrual bleeding, and psychiatric or mental disturbances. Diagnosis of Cushing syndrome is initially based on measuring the free or unbound cortisol in a 24-hour urine sample, in order to assess the total amount of cortisol excreted in the urine over a 24-hour period. Alternatively, blood or saliva tests late at night can help check if there's a normal daily rise and fall of cortisol levels. Another option is also the dexamethasone suppression test, which is when a person is given a low dose of dexamethasone, which is an exogenous steroid that suppresses ACTH production in the pituitary gland. Normally, that should cause a decrease in serum cortisol levels, but if Cushing syndrome is caused by endogenous cortisol production, then the serum cortisol levels should remain unchanged. If that test is positive, the next step is to determine the exact cause of endogenous cortisol production, and ACTH plasma levels can be checked. Low ACTH levels can be seen in adrenal adenomas and carcinomas, whereas high ACTH levels can be seen in Cushing disease and ectopic ACTH production. If the ACTH level is high, the next step is to give an injection of a high dose of dexamethasone. Unlike pituitary adenomas, ectopic sites of ACTH productions typically don't respond even to high doses of dexamethasone, and the serum cortisol remains high. After all that, imaging can be used. An MRI of the pituitary gland in the case of Cushing disease, a CT scan of the adrenals when adrenal pathology is suspected, or a CT of the chest, abdomen, or pelvis if there seems to be an ectopic site of ACTH production. Treatment of Cushing syndrome depends on the underlying cause. If it's due to exogenous medications, then the offending drug is gradually decreased and eventually stopped if possible. It's important to avoid sudden steroid withdrawal, though, because that can cause an adrenal crisis, which is life-threatening. That's because the adrenal glands might be atrophied and might need months to recover fully, and during that time, the body needs the exogenous steroids to function normally. If Cushing syndrome is due to a pituitary adenoma, like in Cushing disease, then surgical excision of the adenoma might be needed. Alternatively, medications like adrenal steroid inhibitors, like ketoconazole and metirapone, can be helpful, especially for cases of ectopic ACTH production or adrenal carcinomas that have already spread. Alright, as a quick recap, Cushing syndrome is any condition or situation that causes increased levels of cortisol. It can be exogenous, meaning drug-related, or endogenous, meaning that it's from an adrenal tumor or excess ACTH from a pituitary adenoma, in which case it's called Cushing disease, or from an ectopic site like small cell lung cancer.
Hey guys, thanks so much for watching. This one was kind of a long one, but hopefully you learned a lot more about Cushing syndrome.
All right.
Special kudos to Antonia providing this awesome script, Rishi and Kai.
Okay. So there is a lot there to sort of unpack. But I like that video because it explains what happens when we see that we have elevated cortisol levels. First of all, we see that the results of the elevated cortisol are far-reaching. Their video went over some things that I hadn't even mentioned yet. But the results of that elevated cortisol are kind of far-reaching. But then the question is, where is it, right? Is it coming from the adrenal cortex itself, if we have a tumor on the adrenal cortex? Or is it coming from a source upstream? If we have a tumor on the anterior pituitary, maybe we are releasing too much ACTH, and that's causing the adrenal cortex to release the cortisol. Okay? So in your guys' announcement this week in Canvas, I have given you a list of topics for this unit, and I also included an additional review question that deals with a dexamethasone suppression test and a couple of different patients to where I would like you guys to try to diagnose maybe where the elevated cortisol is coming from based on those test results. So it's kind of an interesting thing that we have here, and it's I think a really good video. He does a good job of kind of laying things out. He goes a little bit fast, so you might need to watch it once or twice. But I made that link live in Canvas so that you guys can access that video when you need to. There's a second one, and I can link to that as well. If we come here, it's osmosis. The opposite is Addison's disease, which is primary adrenal insufficiency. So this is the opposite here. And I can link to this one as well. This one is also a really interesting one that we have. You can watch a few minutes of that at the time.
Primary adrenal insufficiency is a rare endocrine disorder that happens when the adrenal gland isn't able to produce enough of the hormones that the body needs, particularly aldosterone and cortisol. The reason it's called primary is that the underlying problem is localized to the adrenal gland itself, rather than a problem of a hormone that acts on the adrenal gland or elsewhere in the body. Primary adrenal insufficiency can develop acutely or chronically, and a really famous example of someone having this condition is John F. Kennedy, who was diagnosed at age 30. Now there are two adrenal glands, one above each kidney. And each one has an inner layer called the medulla and an outer layer called the cortex, which is subdivided into three more layers: the zona glomerulosa, the zona fasciculata, and the zona reticularis. The outermost layer is the zona glomerulosa, and it's full of cells that make the hormone aldosterone. Aldosterone is part of a hormone family, or axis, which work together and are called the renin-angiotensin-aldosterone system. Together, these hormones decrease potassium levels, increase sodium levels, and increase blood volume and blood pressure. Aldosterone is secreted in response to elevated levels of renin.
We'll talk
And its
about
role is
this
to
with
bind
the
to receptors
kidneys.
on two types of cells
Don't
along
worry
the
about this
distal
yet.
convoluted tubule, the nephron. First, it stimulates the sodium-potassium ion pumps at the principal cells to work even harder. Potassium concentration gradient. Pumps in alpha inter. The middle layer of the adrenal gland is the zona fasciculata, and the cells there make the hormone cortisol, as well as other glucocorticoids. Cortisol is needed in times of emotional and physical stress, like arguing with a friend or fleeing from a pack of raccoons. In those situations, the hypothalamus, which is an almond-sized structure that sits at the base of the brain, releases corticotropin-releasing hormone, which is then received by the pituitary gland, the pea-sized structure sitting just under the hypothalamus. In response, the pituitary gland sends out adrenocorticotropic hormone, or ACTH, which travels through the blood to the zona fasciculata of the adrenal glands and signals cells there to release cortisol. Cortisol is a lipid-soluble molecule, meaning it can mingle with fats, which allows it to easily pass through the plasma membrane of cells and bind to the receptors inside. In fact, almost every cell in the body has cortisol receptors, so it affects a huge variety of functions in the body. One of cortisol's main jobs, though, is to increase blood glucose levels by promoting gluconeogenesis in the liver. Gluconeogenesis is the formation of glucose from non-carbohydrate sources, like amino acids or free fatty acids. Cortisol also gets the muscles to break down proteins into amino acids and gets adipose tissues to break down fats into free fatty acids, both of which help provide the liver with more raw materials to work with. So basically, cortisol keeps blood glucose levels high, and this is in contrast to the hormone insulin, which causes glucose to be taken up by various body tissues. And so essentially, cortisol acts to counteract this effect in an effort to make sure that the body can respond appropriately to those raccoons or other stressors. Finally, the innermost layer is the zona reticularis, and the cells there make a group of sex hormones called androgens, including one called dihydroepiandrosterone, which is the precursor of testosterone. So the adrenal glands are involved in testosterone production in both men and women, but the amount that the adrenal glands actually contribute is pretty small, relative to the testes in men, which account for the very different levels of androgens in men versus women. In men, high levels of androgens are responsible for the development of male reproductive tissues and secondary sex characteristics, like facial hair and a large larynx, or Adam's apple. In women, low levels of testosterone are responsible for a growth spurt in development, underarm and pubic hair during puberty, and an increased sex drive in adulthood. The exact mechanism for adrenal androgen production isn't well understood, but like cortisol, it seems to be stimulated by adrenocorticotropic hormone, released from the pituitary gland. So that all brings us back to primary adrenal insufficiency, where the adrenal cortex gets damaged. This can happen acutely or chronically. Acute primary adrenal insufficiency can arise from Waterhouse-Friderichsen syndrome, which is when a sudden increase in blood pressure causes blood vessels in the adrenal cortex to rupture, filling up the adrenal glands with blood and causing tissue ischemia and adrenal gland failure. Chronic primary adrenal insufficiency is also called Addison disease, and in high-income countries, the most common cause is autoimmune destruction. This is when the body's own immune cells mistakenly attack the healthy adrenal cortical tissues, though the precise reason why this happens isn't clear. In the rest of the world, the most common cause of Addison disease is tuberculosis. In this case, the infection spreads from the lungs to the adrenal glands, causing inflammation and destruction in the adrenal cortex. Another important cause is metastatic carcinoma, which is where cancer spreads to the adrenal cortex from somewhere else in the body. Regardless of the cause, it turns out that the adrenal cortex has a high functional reserve, meaning that a small amount of functional tissue can still do a pretty good job of churning out enough hormones to meet the body's needs. As a result of this, though, once there are symptoms, it's usually a sign that a majority, sometimes up to 90%, of the adrenal cortex has been destroyed. The symptoms of primary adrenal insufficiency correspond to which layers of the adrenal cortex have been destroyed. When the zona glomerulosa is destroyed, aldosterone...
All right, I'm going to stop there because we are almost out of time. I will link to this, though. If we have time in lab, we can sort of pick back up where we're at and finish watching this. I think